Good afternoon. And today we have a very special guest, Dr. Brian Hockel. He is not only orthodontist, or let's say general dentist, who after observing what's going on, become an orthodontist and doing orthodontics for 25 years, but also, and he's doing very special type of orthodontics called expensive orthodontics, not expensive, but expensive, which is priceless for your health. He's also explore the treatment options himself, and he's gonna share his journey with us. Good afternoon, doctor.
Good afternoon, Maria.
And thank you to our audience. If you have trouble sleeping or sleep next to the snoring partner, that might be interesting program for you, because you can improve your health and also ensure the health of your future generations would be better, or your kids can get healthier. If you're a medical professional who, just like us, looking for all missing pieces of puzzle to have a healthy life or healthy life for their patients, you want to support a healthy life for their patients, that program would be very interesting for you. And I'm going to start with my story with Dr. Hockel. So I tried to bring him on the program for the last 6 months. He's very busy practitioner. A lot of people flying across the world to get his treatment done, because that's so unique. Also, he is a generational dentist. That says his father was a dentist, he followed his footsteps, and he kind of accumulated the father's wisdom. And he focused on treatment what protects airway or enhance the airway. He graduated from a lot of programs, and he's a board member of Academy of Airway and Gnatologic Orthopedics. So he's very active to advocate for people who don't have a good airway health. Lectures a lot on non-retractive and airway orthodontics. But another wonderful thing, actually, I was introduced to Dr. Hockel through this wonderful group of pulmonauts, because additional to being talented doctor and father of 11 kids, Dr. Hockel also play bass in that group called Pulmonaut, with a lot of dentists, doctors who / musicians, and they promote the idea of healthy airway through the music. And I love that when art mixed with the science, it creates such a spicy atmosphere. I love it. So my first question to you, can you please tell us what made you to choose non-retractive orthodontics?
I chose non-retractive airway orthodontics because to me that's the same thing, or it's a critical part of health-centered orthodontics. It's always healthier when you don't reduce the tongue space. And if you retract and pull teeth backward, the tongue space gets less, and that's never good.
But I interview a lot of airway-centric orthodontists, but they didn't talk much about retractive. What's so special about your way of treatment planning and promoting presenting your treatment to the patients? What options you offer to your patients?
Well, I offer options that are not retractive. Anything that will increase the amount of space the tongue has is acceptable. Anything that might decrease the amount of space the tongue has is not acceptable. So when the front teeth look like they stick out, the most common treatment is to pull them back. That's not good, because it reduces the tongue space and it might push the lower jaw backward into the joint, causing problems in both areas. It might not, but how can we as the practitioner ever be certain that it won't?
But I'm wondering how you can do without retraction if teeth have spaces. Spaces between the teeth are not so acceptable socially.
That's a very good question. So the answer to that is you can leave the teeth in the arch form where they are and bring the front teeth together where you don't see any spaces, and just move the space further back into the arch, somewhere where it won't be a cosmetic or a functional problem. If there is a little space there at the end of treatment, it can generally either be filled in with filling material or by some other restorative means. Sometimes there's so much space you can put an implant in, put another pull tooth in. There are always ways to add the width of the teeth or additional teeth, but it's better to do that than it is to decrease the amount of space that's available.
I'm wondering, I know about your own health journey, and you have wonderful slides to show that. What exactly happened with you? Why did you decide to do your own treatment in a certain way?
Well,
I'm gonna add the slides to the stage. Yeah.
Okay. And let's see. Well, here's my description of retraction. I don't know if you want to see that picture there, but retraction is pulling back. Whenever you pull teeth backward in the mouth, that's not good. And this is the most common reason is when there's overjet, you see the front teeth being pulled backward, and it makes the teeth closer together, but it causes the tongue to have less room, and that can be bad for the airway. So that's a good example of retraction. When you mentioned spacing, and spacing is one of the 7 reasons here why we tend to retract. We think we have to have class 1 molars. It turns out we don't. We think that most spaces are bad and have to be closed all the way. And it turns out they don't all have to be closed all the way. It's often better to leave the space. A third reason is because we want to reduce the overjet and pull the front teeth backwards so they match up with the lower. This is a difficult one because a lot of people are told that with the Herbst appliance or the Invisalign MA or the Twin Block or other appliances, they think they're bringing the lower jaw forward. But what happens is it might come forward a little bit, but more often than not, the upper teeth are pulled backward in the same way that a headgear would. So to answer your question, I wore a headgear for a short time, and I had other types of orthodontics when I was younger that were retractive, and it gave me a good bite, but we didn't understand at that time what was wrong with pulling teeth backward. And we need to make the teeth fit. There isn't a great alternative to be able to make the whole lower jaw come forward. Other reasons are we think that when it's too crowded, we have to take teeth out, and that ends up causing retraction. Premolar extractions, yeah. Or someone might say, oh, the profile's too full. Your lips stick out too far. So we have to remove teeth and pull everything backward to flatten the profile. And that causes a lot of retraction, especially for Asian patients. And then there's kind of this silly game we play with cephalometrics or with analyses that are done with 3D imaging, where we think in order to satisfy these arbitrary cephalometric norms, we have to pull teeth and pull the teeth backward in the face. So, but we're airway orthodontists, right? We do airway treatment, not us. We don't retract. But I think if we're honest about it, the appliances that can definitely have a risk of retracting the front teeth include all of these on the right side of the screen. The Herbst appliance, I don't think anyone would argue. Some people have even called it an invisible headgear because it pulls the upper backward. All these other things, but look at the very bottom, the MyoBrace or the Invisalign MA. Even appliances like those can at times be retractive. So the key to it is Newton's third law. When you have a action, there's an equal and opposite reaction. The action of pulling the lower jaw forward will tend to pull the upper jaw backward. With the MyoBrace, it's retractive when there's overjet. With overjet, the child has to posture their lower jaw forward into the trainer. And then as they hold that position, the lower jaw wants to come backward, and it's putting a retractive force on the upper teeth. So a lot of times the overjet is reduced by pulling back the upper teeth and maybe a little bit of forward movement of the lower teeth. So even those appliances can be retractive. If the teeth were edge to edge, I don't think a MyoBrace is going to be retractive. But a lot of times it's used in cases where there's a lot of overjet.
Yeah, that's an interesting point. And I'm wondering, as a dentist, number one, you talk about premolars, and I always love to say that phrase. It's in a sarcastic way. It's a kind of a joke because I constantly see that what people who had orthodontic treatment many years ago, and up until now, and had 4 bicuspids removed, they actually put the bread on my table, and it's a lot of bread. I see the TMJ and sleep problems with them every day.
Exactly. So my goal is try to treat the structure, reopen the spaces, or open space where there was never space before, or move the jaws to where they belong to try to keep them out of a TMJ office or a sleep apnea appliance office. I mean, we really should not retract. There are some major reasons why we shouldn't retract. The first of which is it can make the airway smaller. There are studies that show this. There's really no doubt that it can happen. It doesn't always happen. So someone might say, yeah, but the risk is small. Well, how big is the risk? How much risk can we afford to take with something like this?
The lice.
Another reason, when you pull teeth backward, it'll often pull the whole lower jaw backward. It can force the lower jaw into a retruded position, which isn't good for the joints. Most commonly when people have TMJ problems, the joints have been pushed backward one way or another. So that's the second reason, avoiding mandibular entrapment.
And that's put the bread on my table as well.
Oh yeah, definitely. And you've heard the term extraction, retraction, regret syndrome. This was coined by Dr. Bill Hang, having seen many patients. He calls it a constellation of symptoms that are emotional, functional, and cosmetic, and it can affect different people in different ways, but it can destroy someone's life. It can be very harmful. And the word is out there now. Look up the Facebook group Extraction Orthodontics Reversal, or I think that's the name of it. There are hundreds of people who've answered a survey on there talking about what harm was caused by pulling their teeth backward. And the profession can stay in denial, but there's no denying it now. Retraction orthodontics can cause a lot of problems.
That's a serious thing. But tell me, what's the answer to that? How, a practitioner like me who's so passionate about airway and keeping airway as wide as, the train can go through, what can be done to still accomplish the aesthetic? I know you answer one question, what we can keep the space, but if we start with little kids and, we already see, what's going on in Maya brace, I thought was a great option, but seems like it's not.
Well, the short answer to your question is get the person to grow right in the first place. If the oral posture is correct, lips together, teeth together, or very slightly apart, the tongue solidly against the roof of the mouth, breathing through the nose, then the growth is going to go in a direction so we're not tempted to do retractive orthodontics. Retraction is a strategy to make teeth fit on jaws that don't fit most of the time. And if we could just get the jaws to grow correctly, that would be a much better option. The key is start early. When you start early and you can correct the oral posture, get nose breathing, tongue to the palate, the earlier the better. That's what's going to give you the best growing face. But it's much easier said than it is done, because there are factors that are involved.
That's why I use my brace as a magic answer to kind of do the better habits. The Maya brace not only, the appliance what can shape the jaw, but also, form the certain habits, or at least open the message, or maybe have like magic bullet idea. I'm not talking about magic bullet, but magic bullet idea, what people can, get better that way. That's...
Yeah, I'm not so sure there's any magic answer, Maria. I think whether it's the Myo brace or any other type of trainer appliance, just putting something in a kid's mouth and having them stay for a certain amount of time, there are improvements that can be made, but I'm not so sure that's the way to get lips together, teeth together, tongue to the roof of the mouth, and all the time. It involves so many other things. You've got to have the right diet, foods that require the muscles to work. You've got to breastfeed from a young age. You've got to avoid bottles, pacifiers, sippy cups, things that are going to remove the tongue from where it belongs. Those are all not so easy.
No, and you know that from practice, you have 11 kids. But now I really want to know what happened with you. Tell us your story.
Well, let's see. Oh, I will do that. I'll tell you my story. And on this slide, one of them is my story. It wasn't about just expansion, which is one of the strategies we can do. It wasn't about wearing a headgear to pull my upper jaw forward, which it could have used at a younger age. It wasn't about leaving spaces because I had too much space. It wasn't about doing orthotropics to get the jaws to grow further forward, because I was done growing. I was 60 something. It wasn't about creating space for extra teeth. These are all things that I do for people depending on what's appropriate for them. Or extraction reversal. This is using a sagittal appliance to reverse the extractions that were done before and the retraction that followed. Sometimes we have to bring the lower front teeth forward to camouflage the class 2 overjet. And that's what the bottom right picture shows there, bringing the lower front teeth forward to camouflage overjet. It's not retracting, it's making more room.
I like that term. I want you to say again, what exactly mean camouflage overjet for my audience who not dentists?
So camouflage means to hide something, right? If you wear camouflage clothes, you're hiding something that would otherwise be obvious. When somebody has overjet, where the lower jaw is too far back, the upper jaw is also too far back most of the time, but it's not as far back as the lower. So there's a big distance between the two. And people say, my teeth stick out. When are you going to pull my top teeth backward? In the airway world, we say, we're never going to pull those backward. In fact, sometimes we bring them more forward. But if we want to camouflage that overjet, the distance between the two, we can just bring the lower front teeth forward a little bit, or sometimes even all the way, and they can move quite a long distance. People will say, oh, you can't do that. You'll push the teeth off the bone. No, you won't push the teeth off the bone. There are limits to what you can do, but this is very, very doable in a lot of cases. So bringing the lower front teeth forward camouflages the distance from the top to the bottom when somebody's lower jaw is too far back. It's one of the strategies for dealing with overjet in a way that isn't retractive. You can do the same thing with class 3 overjet. When the upper teeth are way far back, you can camouflage it by just bringing the upper front teeth forward, and it'll typically open up space in the back when you do this. But that doesn't hurt anything. I've checked, there is no law against space or extra space between your teeth in the back. So that's what camouflage is.
No, that's a beautiful story. So please tell us your story. What happened with your airway?
My story, let's go ahead to my story here. I took an x-ray of my airway, and I found out that at the smallest area, it was only 22 square millimeters. That's really small. Just so everybody knows, it really should be over 100 to 200. It's great seeing 300 or 400, but when it's down below 100, it becomes a very big risk for the airway not working well. I snored sometimes. I had difficulty sleeping on my back. I could really only sleep on my stomach or my side. I could tilt my head back and open my airway. But when I saw this x-ray of my airway, I called my friend Bill Hang and said, you've got to put braces on me. I need to get going. I'm moving my jaws forward. I want a bigger airway. I'm not going to wear a CPAP. An oral appliance is not going to do it for a case like this. Just widening my arches, like with some kind of a MARPI or MSE, wouldn't be enough. Or just doing, sleep hygiene or myofunctional therapy. I don't think any of those would have been possible to have me. They wouldn't have worked to help me reach my goal. So there I am, right after doing double jaw surgery with Dr. Reza Movahed. And here's 1 day before and 3 weeks after, showing the different position of my jaw. Both the upper jaw and the lower jaw are moved forward and at the right angle so that the airway will open up. And when you look under the surface, I've got a custom plate. I've got some plates on my lower jaw. You don't see it when you look at me, but that's what's holding my jaws. Well, it was holding them initially. Then the bone fills in and it's just there. I had a tongue tie release. I did myofunctional therapy with Joy Moeller. And the difference is that I can now sleep on my back very well without snoring, and my jaw feels comfortable where it is. It doesn't feel like it's pushed back. But look at this. The airway is 12 times bigger than it started out, 266. And that can really only be done for somebody like me by doing the double jaw surgery. There are other workarounds. A CPAP is a workaround. An oral appliance is a workaround. But don't forget, oral appliances are retractive. Any millimeter forward the lower jaw is brought is a millimeter that it wants to pull back the upper and have a retractive change on the upper. So if you really want to do it right, surgery done the right way with the right surgeon, with the right orthodontics before and after, the right protocol, the right plan, it can be very successful. If any of those rights is wrong, the wrong surgeon, the wrong plan, the wrong protocol, the wrong kind of orthodontics, believe me, there are a million ways to mess up double jaw surgery.
No, but I mean, you look much younger now than 10 years ago. I mean, we still
Yeah,
have
that was
some
9 years ago.
Yeah.
Sadly, now that I can eat better, I put on a lot of weight after my surgery, and I'm working on taking that off. But I think without a doubt, I wouldn't go back if I had the choice. So,
No, life
yeah.
is constant challenge, and we just get on the road and keep driving. But to answer to our audience, from the young age, what the strategies you recommend to clinicians and parents how to make right journey, how to have a right directions of the journey?
I think the best thing is study about oral posture and incorporate that. Know that the causes of poor facial growth, the causes of crooked teeth are things that can be addressed in the right way. They're not easy to address, but you're going to need a myofunctional therapist on your team, whether they come from the speech therapist background or the dental hygiene background. Doesn't matter to me at all. Their competence and what they've learned since they became credentialed is what makes them valuable. You cannot treat young kids without having a myofunctional therapist on board. And doing things early on to develop more space for the tongue to help catch up for lost time and make room for the tongue is a very common strategy we'll consider at the younger ages. So that's only a small piece to the pie, but it's the piece that I focus on in our office, the things that we can do to help out.
But my last question, the tricky question, a lot of people say teeth are sticking out, and we call it lip incompetency. Sometimes people not able to put the lips together. I understand, you expanded in the back, but in that story, how do you address the lip incompetency?
It depends on what the cause is. A lot of times it's because of vertical growth of the face, and the distance from the chin to the nose is very great, and the lip really has a very hard time reaching the upper to the lower. It could also be because of the position of the teeth. The teeth might be in the way of the lips being able to come together. So you have to fix the structural issues first if there are any. But having said that, I think a lot of people might say they have lip incompetency, but what they have is a muscle that hasn't been trained. They need to do myofunctional therapy, sometimes release a lip frenum to be able to posture more passively closed. And with the myofunctional therapy, they can be trained to do it even where they might not think it's possible. But then at nighttime, every night, I've got my little roll of tape next to my bed. I tear off a little piece of it, put it from top to bottom lip, and I'm not going to stay awake all night to make sure I've got lip competency. I'm just going to make sure I only breathe through my nose.
This is a beautiful practical advice. Thank you very much, Doctor. We really enjoy our very lively conversation with a lot of controversy to the community. But thank you very much. And we're looking forward to more discoveries from you.
Thank you, Maria.